let's talk a little bit about the frequencies. They were developed in the early 1900s and used by thousands of physicians until 1934. In 1910 or 12, the Flexner report came out and said that medicine needed to be standardized by creating medical schools and standards of practice, so that if somebody went to an MD any place in the country, they could be assured of having somebody that had been trained and that would practice more or less the same way. But up until about, up until the 1930s, that just wasn't the case. There were no medical schools, there was no standard of practice, there was no consensus or agreement about how a medical physician should treat patients. So about so the Flexner report came out in 1917, the American Medical Association got a little more intense about, hey, we're really serious about this. 1934, the American Medical Association came out and said, okay, this is it. Anybody that uses electromagnetic therapies, nutrition, homeopathy, or herbs will lose their license to practice. We're serious about this. And the license to practice back then came from the American Medical Association. That was the standard. There were no state licensures until the 40s, 50s, I think. And Harry Van Gelder was a naturopath and osteopath who came over from England after the war, bought a practice in 1946 that came with a machine that was made in 1922, and that machine came with a list of frequencies. I got that list from George Douglas in 1995. I started practice in 94 and started treating myofascial pain patients and fibromyalgia patients. And George had the list, gave me the list, and in 1995 we started treating patients together. 1996, I started treating myofascial pain patients myself, and our results in 96 were so extraordinary in myofascial pain and trigger points that we decided I had to teach it in 1997 to find out if it was reproducible. It's like, is this for real? Is it really that good? If it's for real, then it's reproducible. So I can teach a class and we'll find out if anybody can have the same results. Was it that the frequencies really worked, or was it that I was a nice guy and the walls in the clinic were pink? So we taught it January of 97. By June of 97, we knew that the frequencies were reproducible. We knew that anybody could do it. The fact of the matter is, what everybody wants to know is, how did they derive the frequencies? And that we'll never know. In 1934, when they said you have to stop using these devices and these frequencies to treat patients, the machines went in the back room, got covered up with a sheet. Harry came along and took the sheet off and started using the unit, but all the rest of them, as far as I know, in the back room with a sheet over them. And then when Dad or Grandpa died and the family had to clean out the office and get rid of the equipment, and the devices ended up in the junk heap, the research stopped back in the late teens, so 1917 to the last issue of Electromedical Digest was published in 1951. But in the 20s and 30s, the journals that they wrote stories in and all of that, those journals just went away. And the people who were using the frequencies passed on. And the people that had derived the frequencies working together between 1908 and about 1935, they passed away. And once they died, and once those journals went into rare book rooms or the Quack Museum or wherever they went, once that information was lost, it's lost. So Point of fact, I have no idea how they derived the frequencies. There was something about tapping, and there was something about tones, but how somebody in 1934 or 1922 decided that the frequency for the tendon was 191 hertz and the frequency for the burst is 195 hertz, nobody knows. The mechanism of action we're not sure about, but I would say that now we have a better idea of the mechanism of action than they did even back in the 1920s. As you'll see in a bit, we think that the frequencies affect cell signaling and the bonds bonds that are created in the membrane protein receptors that affect cell signaling. But that still is theoretical. We have no idea how they work. I have no idea where they came from. I'm a clinician. I'm a researcher. I'm a clinician. My job is to fix patients. So back in 1995, when we resurrected the list, I had no idea if they were going to work. So the question was, do they work or don't they? And if they work, how do we get them to work better? And how do you use them in any particular patient complaint? I can tell you that the 1920s equipment was not microcurrent. It was plug-in-the-wall, DC, direct current before there was even AC wall current. So you can't plug in one of these machines into the wall anymore. They're all battery operated. So that's what we know about the frequencies. There's a significant list between the advanced and the core seminar that I teach. There are quite a list of frequencies, and that's where they came from. This is a book titled The Electronic Reactions of Dr. Abrams. Abrams was a medical physician practicing in San Francisco in the 1920s, and part of our frequencies are ones that we got from a list from the back of Electromedical Digest that sold a poster that was a list of Abrams frequencies that he sold to physicians who subscribed to that journal. If you look Abrams up on the internet, he's listed as a quack. However, he was trained in Vienna, which was the highest level of training that a medical physician could achieve. And anybody that used electromagnetic therapies was listed as quack back then by the AMA in the 1920s and 30s. So you have to take that with a grain of salt. But that's what we know about where the frequencies came from. So old problems in medicine. What is it that we have difficulty healing or repairing? Well, we have difficulty with healing injuries, surgery, and healing wounds. So how do you improve the rate of healing and the effectiveness of healing in traumatic injuries, surgical injuries, and wound healing? Well, from a medical perspective, the repair is limited by ATP production, or what the body uses for energy. The blood supply to the newly created repair tissue, the collagen, which is what you make connective tissue and basement membrane out of, effectively it's collagen, and elastin is what makes repair tissue stretchy and normal. In general, scar tissue is stiff. It doesn't have a normal complement of elastin. So these four problems or issues are what limit our ability to repair new injuries. So if you wanted to increase the rate of healing, what would happen if you could increase ATP, or cellular energy production, by 500%? Well, that is exactly what micro-amperage current by itself does. The current by itself was studied by Nok Cheng in 1982, by J.C. Seegers in 2001 and 2002. And what both of them found in all three studies is that current between 10 and 500 microamps increased ATP production by 500%. That is 5 times the amount of energy that your cells normally produce. With that extra ATP production, the body increased protein synthesis by 70%, increased amino acid transport into the cell by 40%. So if you want to make protein and repair tissue with this increased ATP, you've got to move the amino acids to produce the proteins across into the cell wall, and it increased amino acid transport by 40%. Increased cyclic AMP in human lymphocytes in vivo, so that's in real life. So they tested cyclic AMP, this was Seegers, not Chang, in human lymphocytes in vivo. And Seegers stated that the flow of current activates signal transduction, and that just means that it facilitates the communication between cell membranes. I think they did it in rat skins. Chang was in rat skin. So that's what we know about ATP. Now, microcurrent has to be delivered by a device. Well, the devices in the U.S., actually all over the world, microcurrent devices are approved in the class of TENS devices, even though they're not TENS. TENS devices are milliamps or thousandths of an amp. They cause muscle contraction, they cause lots of sensation, and microcurrent doesn't do that. Microcurrent is millionths of an amp. It's subsensory. It's the same kind of current that your body produces on its own, and you can't feel it. So it's definitely not a TENS. That is, but because it's approved in the category of TENS, it is a prescription. However, the same micro-amperage current is approved by the FDA for aesthetic use, for skin care, and that is not prescription. So you can buy a 2-channel microcurrent device that is not prescription if you buy it for skin care. If you're using it in a medical office, it is billed as if it is a TENS, so there is a certain advantage to having that categorization by the FDA as a prescription, because medical physicians, chiropractors, acupuncturists, and physical therapists and occupational therapists can bill for it as attended electrical stimulation. Microcurrent devices vary widely. They're DC, direct current, which means there's no waveform at all. It's just current flowing from point A to point B. Pulsed DC current has circuitry in it that create waves, and there are different waveform devices out on the market: square waves, sine waves, ramp square waves, tsunami waves in the old wing machines, and there's even an H wave that is microcurrent. They have 1-channel devices, 2-channel devices. There are combined units where you can get ultrasound, interferential, galvanic, and microcurrent. But in all of these old original microcurrent devices, microcurrent was introduced in the 1970s and 80s and kind of lost favor in the early 1990s. The frequency in all of those old machines, microcurrent machines, was not important. There was either a limited number of frequencies, 0.3 hertz, 3 hertz, 10 hertz, 40 hertz, 300 hertz. There's a limited number of frequencies, or there was one device that did a sweep of frequencies just sort of automatically from 1 to 1,000 and back to 1 again. And the machine just ran that sweep no matter what the patient had going on. So what do we know about microcurrent, the current itself? 20 days of microcurrent. This was done in rabbits, which is what you do if you're studying the effect for aesthetics use. This is unpublished data because estheticians don't really care about peer-reviewed published papers. So this hasn't been published, but it was done at University of Washington in Seattle. It was done in rabbits biopsies. So they biopsied the bunnies on day 1, and 30 days later, so 4 5-day weeks, so the rabbits were treated Monday through Friday for 4 weeks, so that's 20 days of microcurrent. It was a graduate student research project. Biopsied the bunnies, treated the bunnies, then biopsied the bunnies again, and there was a 39% increase in vascularity, or the blood supply in the muscles and the fascia in the rabbits. collagen increased by 14%, but elastin, this is the interesting part, especially for estheticians and for wound healing, elastin increased by 48%. So the tissue was not only had better blood supply, collagen increased by 14%, and elastin increased by 48%. So in repair tissue, that would mean that your new repair tissue would be stretchy and more normal. So you have to ask yourself, what would happen to injury and wound healing outcomes if you could increase ATP, vascularity, collagen, and elastin? This is just an effect of the current. This is just what the DC current flow does. So we know that the current by itself has those effects. Then the question was, do the frequencies make an additional difference? Are they a benefit in addition to what the current by itself does? And the answer to that came in the paper on delayed onset muscle soreness. The frequencies add an additional dimension to healing and tissue repair that makes a huge difference. So this is a controlled trial in delayed onset muscle soreness. They exercised the patient's hamstrings to the point that they were injured. It's called delayed onset muscle soreness. It's when you work out and get sore. And they compared frequency specific microcurrent to a 1999 paper done by Allen on single channel microcurrent using just 0.3 of a hertz for 20 minutes and 30 hertz, 0.3 of a hertz for 10 minutes and 30 hertz for 10 minutes for total treatment time of 20 minutes. Allen's paper showed that single channel, single frequency microcurrent did not work at all. It was equivalent to placebo in delayed onset muscle soreness. Denise Curtis did this study in Ireland. The frequencies that were used were the frequency to stop bleeding, 18 hertz on channel A and 62 hertz on channel B, repair any micro tears in the tissue, and reduce inflammation in the tissue. So those are the frequencies that are used, and that's available to you on the Frequency Specific website. It's peer-reviewed published paper in JBMT. But these are the outcomes. The baseline, patients had to be out of pain to start with. Then at 1 hour, the treated leg, at 24 hours, the treated leg had a pain level of 1.3 compared to the sham leg. So one of these machines was on and one of them was off. You can't feel the current, so the patient didn't know which one was being treated. Sham leg was a 5 out of 10. The treated leg was a 1 out of 10, so on a 0 to 10 pain score. 48 hours, the pain level was a 1.2 in the treated leg and a 7 in the sham leg. That's why everybody wants to know how to treat delayed onset muscle soreness. And at 72 hours, or 3 days, the treated leg, the pain was slightly less than 1. The sham leg, it was down to a 4. So that p-value, which is a statistical measure of effectiveness, was 0.0005 at all time measures. And I think that means there's less than 1 chance in 100,000 that it was coincidence or it wasn't real. So this is a hugely significant statistical value. And the thing about delayed onset muscle soreness is that there is no other effective treatment. So what this means in the real world, besides to those of us that are weekend athletes, is that hockey teams and Olympic athletes and the National Football League in the U.S., the Eagles, the Broncos, San Francisco, Kansas City, Seattle Seahawks, the Oakland Raiders, and the Minnesota Vikings, and I think there's a couple of others now, all use FSM. Either their players' own units and are treated by FSM-trained athletic trainers, or the team itself owns its own units. If you are having surgery, that's a more controlled kind of injury. And John Cale did this study in 2013. It's not published yet, but he's working on it. The control patients, the patients treated with standard of care after, for example, a C-section or hysterectomy, they were out of the hospital in 3.3 days. FSM-treated patients were out of the hospital in less than 3 days. So it saves them about half a day to a full day as an average in hospital stay. And it reduced their post-op pain. This is significant. It's actually a huge improvement in patient function and recovery, is that their pain was less than a 3 instead of a 5 with activity. So pain at rest is pretty straightforward, but if you think about what they want you to do after abdominal surgery, they want you to get up and walk, and that is not ever much fun. So if your pain level is a 5 out of 10, you're going to walk kind of slow, and you're not going to be too happy about it. If your pain level is a 2 or a 3, it's like, yeah, whatever, let's go around the block. Let's go around the floor. And so it's a huge benefit to patients who have post-op treatment. It reduces bruising, it reduces pain, and improves the ability of the patient to become more active. So it's really helpful in, let's say, hip and joint replacement surgeries where it reduces bruising and pain both. Diabetic wounds are a huge problem in the U.S. This was done back in 2002. It's not published. This was done by Nori Collier. She's a chiropractor in Texas. This patient had a 7-centimeter ulcer on the medial side of his left leg. And this is 9 days later after, I think she's treated 2 or 3 times a week. This wound here on the left is healed. This toe was pretty much set to be amputated. They were just kind of waiting for it to get worse, to tell you the truth, so they could take it and its neighbor off. And at the end of 20 days, it was healed, so it was resolved in 7 treatments. The third digit over here on the left foot was resolved in 7 treatments. This black necrotic second toe on the right was resolved in 12 treatments. So at the end of this treatment period, this patient still had his toes, which was good. Peripheral neuropathy means that your feet are both numb and painful. So in 1 month, this patient went from 7 out of 10 numb areas to full sensation restored in 4 weeks. So that's pretty extraordinary. If any of you have diabetic or peripheral neuropathies, you know what a blessing it is to be out of pain and to be able to feel the bottom of your feet. So that's how FSM helps in wound healing and injury repair. Now, the other old problems in medicine are inflammation, degenerative diseases, and immune system activation. So inflammation is at the heart of every degenerative disease, whether it's your brain, your gut, your liver, your joints, your cartilage. Inflammation is a big problem in medicine. And we have anti-inflammatory drugs, and the anti-inflammatory drugs have some problems. They take too long to work, any place from 6 to 24 to 48 hours to have optimal effects. They have an awful lot of side effects on your ears, on your kidneys, on your intestines, and the inflammatory peptides called cytokines are really hard to change, and when they change slowly. So the biological drugs that they use in autoimmune conditions take 30 to 60 days to change the inflammatory cytokines. Interleukin-1 and TNF-alpha are the ones they focus on as far as I know. So here's a question. what would happen to this problem of inflammation if you could reduce lipoxygenase-mediated inflammation by 62% in 4 minutes? Not 2 days, not 24 hours, not 4 hours, but 4 minutes. Cyclooxygenase-mediated inflammation by 30% in 4 minutes. So the COX inhibitors like Celebrex take 24 to 48 hours to have their maximum optimal effect. And what would happen if you could do that in 4 minutes instead of 6 to 24 hours? Well, we actually had blinded animal research. It didn't start out blinded. It started out with somebody in the veterinary science research center at the University of Sydney in Australia, and Vivian Reeve was the PhD that did this work. They paint arachidonic acid on the mouse's ears that creates lipoxygenase-mediated inflammation, and then they paint myristoyl steroid on the mouse's ears, and that creates COX-mediated inflammation. And with the arachidonic acid and the LOX-mediated inflammation, they had a 70% reduction in swelling in the mouse's ears in response to the use of the frequency 40 hertz on channel A, the frequency to reduce inflammation, 116 hertz on channel B, the frequency to address the immune system. So reduce inflammation in the immune system, and lipoxygenase-mediated inflammation dropped by 70%. Well, Vivian's response was to shut down the lab, because in 18 years of doing this research, she had never tested a prescription or non-prescription drug that reduced inflammation by more than 45%. So she figured everybody had to be collaborating or cheating. So she blinded everybody in the lab. I mean, not literally, obviously. She just moved them all into separate rooms and closed the door. And then she turned the machine away from the man who was treating the mice. This is Wayne Riley. And she put in a placebo frequency. And with everybody being careful, the person who measuring the mice, painting the mice was in one room, the person measuring the mice was in another room, Wayne and herself were in a third room, treating the mice with the machine turned away from him and a placebo frequency thrown in. And with everybody being careful, it was still a 62% reduction in lipoxygenase-mediated inflammation in every animal treated. And all the animals responded. There was no exceptions. And it was a 4-minute time-dependent response. This work was done in 2003. And at the time, we didn't know it was time-dependent. So I was running inflammation for 1 or 2 minutes. And it's half of the effect is present at 2 minutes. The full effect is present at 4 minutes. So that was the first part of this experiment. The reason this is important is that lipoxygenase-mediated inflammation is involved in every degenerative disease: asthma, liver disease, pancreatitis, ulcerative colitis, Crohn's, irritable bowel. Most brain degenerative diseases are LOX-mediated: asthma, chronic bronchitis, COPD. COX-mediated, the 30% reduction is equivalent to injectable Toradol, which is what they give you immediately after hip surgery. So for patients that can't take Toradol or use the prostaglandin drugs, this is a huge benefit in both reduction of pain and the reduction of inflammation. And then, of course, the next thing you want to know is, well, is 40 and 116 necessary? Would any frequency do it? Is this something that just the current does? Is this something that you could do with 0.3 of a hertz? So they used 0.1 of a hertz, just enough to move the current for 4 minutes, and that gave no reduction in swelling. Then they used 4 minutes of our frequencies for reducing mineral deposits in bone, and that gave no reduction in swelling. 4 minutes of the intermediate injury protocol, which is another set of our frequencies, and that too gave no reduction in swelling. And we ran 40 hertz on channel A and the frequency for the skin, 355, and that gave no reduction in swelling. This paper is likewise on our website, frequencyspecific.com. Then the next thing they did is they sunburned the mice. Now, those of you that have had a sunburn know that when you get sunburned, your skin gets red and it gets swollen, and that means it gets sore, and that means it's inflamed. So if you sunburn the mice and don't treat them at all, this is how much swelling there is in their little ears, and this is measured with a caliper, so it's a mechanical measurement of the swelling in the ears. So this is the swelling at 21, 23, 25, and 27 hours. If you treat the mice immediately after the sun exposure or UV exposure, there's some reduction in swelling, but it's not statistically significant. It's a little bit. So this is immediate treatment. Then they treated the mice at 2 hours, another group of mice at 2 hours, and that group reduced the inflammation statistically significant 0.01 and 0.05 at 21, 23, 25, and 27 hours. So if you treat the mice 2 hours after the sunburn, it does reduce the pain and the swelling. However, there was another piece to this that I didn't realize. It's intriguing. Sunburn suppresses the immune response. So at the time of the sunburn, they paint this contact sensitizing agent on the hind leg, and a sensitizing agent is something that you should develop an allergic response to. If your immune system is functioning right, the next time you touch this sensitizing agent, it will cause you to swell. So they paint this sensitizing agent on the hind leg at the time of the UV exposure, and then 2 weeks later, the same agent was painted on the ear. So here's how that works. If you don't sunburn the mice, and you paint oxazolone on their hind leg at time 0, and then paint on their leg at 2 weeks later, then the swelling is 30 units, micrometers actually. And you sunburn the mice, and this is the UV group, their swelling the second time they were exposed to oxazolone was reduced by 63.4%. So this IS is immune suppression, was reduced by their immune response was suppressed by 63.4%. The group that was treated at 2 hours, the one that had the 0.01 and 0.05 reduction in swelling, they had a better reduction in swelling, but their immune suppression was reduced from 63 to 57%. So that was nice. It came down by 6%. But the group that was treated immediately with microcurrent had their immune suppression reduced by half, from 63 to 31%. And here's the trick. Here's the impressive part. It was reduced by half 2 weeks after a single 4-minute application of one and only one frequency combination. So you sunburn the patient, the mouse, you paint oxazolone, then 2 weeks later you paint oxazolone again. And the only treatment was right at the time of the sunburn, okay? And the immune suppression was reduced by half 2 weeks after the application of the frequency. So what that means is a single 4-minute application of one and only one frequency combination changed the immune system permanently after a single application. So it helps to explain why it is that FSM is so helpful in conditions like asthma, emphysema, irritable bowel, Crohn's disease, pancreatitis, ulcerative colitis, liver disease, rheumatoid arthritis, and degenerative arthritis. Most of these conditions are certainly not a one-visit fix because people are kind of big mice, but it gives you an idea of why the frequencies are so useful in these degenerative conditions. So inflammatory cytokines are difficult to change with medication. It takes 30 to 60, sometimes even 90 days to find out if the biological drugs are going to work to reduce the inflammatory cytokines. And the problem with the biologicals is they drop the cytokines below the normal range, and that creates some side effects that are not helpful. So what would happen if you could reduce them all in 90 minutes and they all stopped in the normal range, which is much desirable? Well, this takes us to the paper that I published on the treatment of fibromyalgia associated with spine trauma. It was published in 2005. We did the work in 99 and 2000. We had 54 fibromyalgia patients who walked in the door with a history of trauma, average of 9 years chronic. We did blood sample data on a subset of 6 patients that we sent to a colleague, a friend at NIH, who did microimmunochemistry on it to tell us what the levels were. And the patients that we had the cytokine data on did not differ in age or chronicity. We did the work in 99 and 2000. It took 5 different journals to get the paper accepted because the changes in cytokines are so dramatic. I think nobody believed it. And also the first 3 or 4 times we submitted the paper, I made the mistake of titling it Resolution of Fibromyalgia Associated with Spine Trauma, and basically nobody at a medical journal wanted to hear that fibromyalgia was curable. So we had to make it about the cytokines and not the fibromyalgia. The control patient had myofascial pain and trigger points and did not actually have fibromyalgia. So fibromyalgia associated with spine trauma accounts for 28% of the fibromyalgia patients. We think it's actually closer to 35, maybe even 40% of the patients. There's 6 million people with fibromyalgia in the U.S. alone, and that gives us 2 million patients who have fibromyalgia associated with spine trauma. There's only one frequency combination that is effective. Now, it was clinically 40 hertz on channel A and 10 hertz on channel B. 40 hertz is the frequency to reduce inflammation. 10 hertz is the frequency for the spinal cord. The pain went from an average of 7.4 down to a 1.3 in 90 minutes. The recovery was individualized. FSM in the office and FSM home unit, they had physical therapy, reconditioning, they had supplements. We still had to treat irritable bowel, the adrenals, interstitial cystitis, the other things that fibromyalgia patients get. And this is what happened. All of the inflammatory cytokines dropped. This is the first patient, her interleukin-1. It's one of the cytokines that's associated with inflammation in the nervous system, which means that it would be elevated in things like Alzheimer's and different kinds of brain injuries and dementias. Interleukin-1 went from 392 down to 21 in 90 minutes. The thing about cytokines is that when they change slowly, and they certainly don't change like this. They change slowly over weeks or months. They don't change at this rate, and they're hard to change. So we had 5 patients in the first data collection. This patient didn't respond with a reduction in pain, but her interleukin-1 did come down. TNF-alpha came down from 300 down to 20. These reductions in inflammatory cytokines are historic, like they don't happen. They've never been seen anyplace else. The control patient had myofascial pain from trigger points. It wasn't her spinal cord. It was simply muscle knocks, and those got better. Her pain came down, but she had no elevations in cytokines, and so they didn't change. Interleukin-6 went from 200 down to 15. Substance P is created in the spinal cord. It's a little peptide that mediates pain or is present when you are in pain. And it's manufactured in the spinal cord. So when it goes down, you know that what you're treating is your spinal cord. So it went down from 132 down to 10 in 90 minutes. And if you look at, here's the patient that didn't respond with a reduction in pain, but her substance P came down. She did call the office the day after this data set, this collection, and said, by the way, her legs were out of pain for the first time in 12 years. The rest of these patients had their substance P come down by that amount. Endorphins went up. These patients get stoned. There's just no other way to put it. This is the first patient we did. Her endorphins went from 5 to 88 in 90 minutes, average 8.2 up to 71, so you go up by 10 times. Endorphins are what go up and make you feel all floaty when you're running a marathon, so you have to run a long way to get a 10-fold increase in endorphins. And by about the 30 or 40 minute mark, the patients are stoned enough, they would really prefer not to talk. It's pretty fun. And it's completely legal in all 50 states. Cortisol went up, and you could think that cortisol going up could be a stress response, but it's not, because neuropeptide Y, which follows the stress system, the sympathetic system, it went down. So cortisone went up by a factor of about 10 times, from 15 to 170. And it's actually just a side effect of the endorphins going up. You create the chemical that drives cortisone up. Pain was reduced from an average of 7.3 to a 1.3. This p-value is a measure of statistical significance, and the p-value actually has 6 zeros. It means there's absolutely no chance that this was a coincidence. It means that the treatment that was initiated at the beginning and measured at the end was what caused this drop in pain. All of the patients experienced pain relief. 58% actually recovered from fibromyalgia. It takes about 3 to 4 months. And better tender point sensitivity, improves sleep quality. One patient relapsed because she went out and worked out and didn't follow directions, but she got better. 13 out of the 53 discontinued treatment for reasons not related to treatment side effects. So all of them got out of pain. And in point of fact, at the end of 90 minutes, if you've been in pain for an average of 7 years, and at the end of 90 minutes your pain level was a 0, my sense is that part of the reason they discontinued treatment is just they don't know who they are. At the end of 60 minutes, if your pain goes from a 7 to 0 or a 1, who are you if you're not in pain? So back in 99 and 2000, we weren't very good at helping patients deal with that existential crisis. And that's gotten better over time. Most of the fibromyalgia patients that are treated can recover. Some of them need a home unit to stay out of pain. This lady is sort of optimal, 18 years chronic fibromyalgia from an auto accident. On December 8th, she had 14 of 18 tender points tender to 1 and 2 pounds per square inch pressure. January 12th, 1 month later, she had 11 of 18 tender points. And by February 8th, she had 7 of 18 tender points and never, and did no longer meet the diagnostic criteria for fibromyalgia. So she recovered from fibromyalgia in basically 2 months. The range of motion improved. Her pain medication, she'd still take 1 or 2 a week. Muscle relaxants, she'd take 1 or 2 a week. She was sleeping well without medication. Her digestion improved. Her IBS resolved. And 6 years later, she was still recovered. So she's sort of like the fibromyalgia poster child. So functional medicine is a modern approach for old problems in medicine. It deals with patient biology and getting that turned around so that it functions more normally. They use supplements, they use herbs, they use lifestyle and diet changes, and it is just an extraordinary advancement in the treatment of chronic illness. The problem with functional medicine, it does work really well, but it takes too long and it costs too much. So those of you that are functional medicine practitioners or functional medicine patients, you're familiar with that. I am a fan of functional medicine, and but it takes too long and it costs too much unless you use frequency specific microcurrent as an adjunct. FSM works immediately to reduce pain and increase cellular energy production, but it needs functional medicine to create lasting and stable improvements. Okay. So other old problems in medicine, nerve pain, muscle pain, and scar tissue. Treatment likewise takes too long, costs too much, and it doesn't work very well. The treatments for nerve pain are, well, basically drugs, and they don't work very well, and by the time you get to a dosage of the drug that is effective, you can't remember what your car keys are for. So if you could find them, you couldn't remember what they were for. So we have a paper published in Neuropathic Pain. It was published in 2010. It's just 20 patients where I had in the chart all of the data that I needed. So we've actually treated hundreds and hundreds of patients for nerve pain. It's one of the easiest things we treat with FSM, but these are patients that qualified for this paper. Average chronicity was 7 years. All the patients experienced pain reduction. Like there's nobody it doesn't work on when it comes to nerve pain. The pain was reduced in the first treatment from a 6.8 to a 1.8. And then when they came back for the second treatment, it was still at a 4.8, so it was less than it was when they came in the first time, and it went down to a 1. Of these 20 patients, 65% fully recovered in about 5 treatments. So if you're treating a disc or a nerve traction injury, takes about 5 treatments in 3 to 4 weeks. No adverse reactions except they get kind of stoned. And here we have this 25% terminated care prior to recovery. And once again, they all got out of pain, but they stopped coming in for treatment, possibly because, oh, it didn't last and I don't think I'm going to get better. Or it's honestly, I've been in pain for 7 years, and if my pain goes away, who am I? It's an existential crisis that is unparalleled in medicine. Cervical myofascial pain, 50 cases published in Topics in Clinical Chiropractic. These are myofascial trigger points in the head, neck, and face. The chronicity was 5 years. The range was 1 to 30 years. 88% failed with other treatments, and they recovered. And it took 11 treatments in 8 weeks to get their pain from an average of a 7 out of 10 to an average of a 1.5 out of 10. And it only took that long and that many treatments because I didn't know what I was doing. Most trigger points in the neck and shoulder, head, neck, and face are due to disc injuries, facet injuries, ligamentous laxity, or tendinopathies. And back in 1998, I had no idea about that kind of thing. Lumbar myofascial pain, we got lucky. 8 years average chronicity, the range was about 2 months to 20 years. 87% failed with other treatments, so the patients kind of formed their own control group. They're going to have a placebo effect. They'd have it with one of the 6 other people that had treated them. Took 6 visits in 6 weeks to get their pain down from about a 7 to a 1.5. And you can have a life at a 1.5. Hard to have a life at a 7. So neck and low back pain are fairly straightforward. We treat discs and facets, and honestly, in the lumbar spine, an awful lot of times the problem is visceral. The trigger points in the muscles are created by the ovaries, by the ureter, by the kidneys, by the gut, by the liver. It's been quite a learning experience. We did a project at a burn center in Springfield, Missouri, where we were dissolving scar tissue in mature burns. Did 8 patients, started with 8, finished with 7. One patient, we doubled the range of motion in his hip and his knee in 60 minutes. And he was a work comp patient, and he said out loud, what will happen to my work comp settlement if my range of motion is normal? So he didn't come back for the second treatment. But the other 7 patients had statistically significant permanent increases in range of motion after 3 one-hour treatments. This was done at Mercy St. John's Hospital in Springfield, Missouri in 2003, thanks to Roger Huckfeld and Dr. Bart Flick. Did abdominal adhesion research at Baylor Medical School with Dr. Wiseman. He creates an adhesion in a rat's abdomen, and 1 week, and then the next week we got permission from the ethics committee to go in and open that rat up and see what the frequencies would do to the scar. The scar looked like cartilage. It was white, it was gristly, it was tough. And with the abdomen open, I put the frequencies on either side of the rat's abdomen, and this tough, white, gristly scar tissue literally turned clear and liquefied. We did 3 rats, this one frequency combination, 13 hertz on channel A and 77 hertz on channel B, literally liquefied the abdominal adhesion. We treated 8 patients the next day who had abdominal adhesions and pelvic pain, and all of them were very chronic, any place from 12 to 24 years chronic pelvic pain and abdominal adhesions, usually from endometriosis or Crohn's disease. And this frequency is universally effective in the humans. We used a number of frequencies, but it was just extraordinary research experience, and we're hoping to be able to go back and repeat that in a larger trial with more animals. When you're doing myofascial work on an athlete, and the problem is that he's had a blow to the back where the ureter is glued to the QLs, and the QLs, quadratus lumborum, and the lumbar spine is glued down, and so the lumbar spine is sort of spasmed and weak. Or if there are adhesions between the nerves and the fascia that are restricted, for those of you who are sports medicine practitioners or patients, you put the contacts. This is a graphite glove and a wet towel that serves as a big electrode, and there's another graphite glove and a wet towel on his abdomen, I think. And this is Kim Pittis. She teaches the FSM sports course, and she is mobilizing. So you pin the scar tissue, you run the frequency to dissolve the scarring between the nerve and the fascia, and then you mobilize it. So you move it while you're treating. Those of you that do manual therapy, FSM is a game changer. It gives you the ability to dissolve adhesions between nerves and fascia in the dura, between the dura and the core, the dura and the periosteum. It's an extraordinary advancement. It is a game changer in myofascial work and in sports medicine. It defies description until you see it. It's just hard to believe that it's that easy. So FSM is a new tool. So the frequencies were developed in the early 1900s, the way we talked about. The clinical response is very frequency specific. The frequency effect matches the description. So the frequency 40 hertz to reduce inflammation, reduces pain, reduces redness, reduces swelling, reduces inflammation, doesn't do anything for range of motion. Frequency 51 hertz for fibrosis and 13 hertz for scarring, dissolves the scar tissue, increases range of motion, does absolutely nothing for pain, unless the adhesions or scarring are causing the pain. Frequency to stop bleeding, hemorrhage, 18 hertz. Stops bleeding and pain in the men's season, prevents bruising. Like after my hip replacement, I didn't bruise at all. Frequencies for mineral ion deposits, soften the tissue, reduce pain, some changes in motion. Appears to be pretty good at dissolving kidney stones, given a couple of days or a week. Frequency for shingles or herpes, reduces the pain, eliminates the lesions, and there's a paper published on that. Frequency for kidney stone pain so far has been effective in every case, but it's not good for anything else. So the frequency effect matches the description, and it is clinically effective. So that's where I started, was with a list, and where I ended up was with clinical effects, documenting what it's good at. Shingles case report, this was shingles in the ophthalmic branch of 5 in an 85-year-old man. There's only one frequency combination, 230 and 430, and actually the virus appears to have mutated, so the modification of that is now 230 and 430 and 2:36 and 4:35. 4 hours of treatment. He was pain-free in 1 hour. There was no return of pain. And the blisters, the lesions on his head, were gone in about 48 hours. They were drying up at 24. Most of them were gone at 48. The rest of them were gone in about 4 days. Published that in 2010. You can find those on our website. So the mechanism, how does it do what it does? We've got about 5 minutes left. So the short version is that the human body is a biological system, but it's a quantum biological system. Living tissue, your fascia, your arm, your leg, your bones, they're biochemicals, and they're held together by electromagnetic bonds. So these biochemicals are molecules, atoms, and subatomic particles that are held together by electromagnetic bonds. And in physics, every bond has a frequency that it resonates with, or a resonant frequency that will vibrate with it, that will match it and cause that bond to vibrate and loosen. So your body is an electromagnetic system that looks solid, but the cells in your body function as a semiconductor network. Water molecules line the web, the filling in the cells. Water molecules line every cell in your body and flicker in such a way that it makes the cells into a semiconductor, just like a silicon chip that's in your computer. And so your body as a semiconductor network conveys current, charge, and information. For more detail on this, you're going to want to read Jim Osman's book, Energy Medicine, The Scientific Basis. The second edition is extraordinary. So current, charge, and information are conveyed by your body as a semiconductor. Membrane protein receptors determine cell function. There are little receptors on the outside of the cell that control the genes and genetic expression, what the genes do on the inside of the cell. They're connected. So these receptors can reconfigure in response to stimuli like little pieces of bacteria or chemicals or inflammatory products that turn the cell on or off or change what it's doing in response to its environment. So the receptor changes alter cell signaling, these kinases and transcription factors, and that those changes in cell signaling alter cell function, what the cell does and how it works. So drugs and nutrients, which is what we're used to, act like keys in a lock to change this receptor and change intracellular function. You put the key in the lock, give the patient an Advil or an antibiotic, changes the receptor, that changes the kinases, that changes genetic expression, that changes what the cell does. So you give the patient Celebrex, and it changes, hits the cell like a key in a lock and changes the creation, the production of inflammatory products by the cell. Well, the frequencies act like your key fob. It's why they work faster. When you punch the button on your key fob, it opens that door lock immediately, and it opens it very specifically. The frequencies act like a key fob, opening the same lock with an electromagnetic signal. Your key fob only works on your car door, and it only works on the front door, and then it works on the back door. It is specific to your car. So it changes membrane protein configuration and cell function electromagnetically. When it dissolves scar tissue cross-links, or when it dissolves scar tissue, it acts like it's just vibrating with the scar tissue cross-links and vibrates them apart because the scar tissue just melts. It just disappears. It acts as if it disassembles or inactivates the virus capsid in shingles. It acts as if it changes cell signaling in inflammation. by reading the FSM textbook, Frequency Specific Microcurrent in Pain Management. It's just the pain management applications, the new book. The resonance effect does more of the visceral conditions, but it actually has the protocols and frequency protocols for both visceral and pain medicine conditions. It's taught as a 3-day seminar right now. In September it goes to 4 days because I just can't do it in 3 days anymore. There's too much new information. There's too many practical applications. If you are a patient, I suggest you send your physical therapist, chiropractor, acupuncturist, or MD to come take a class. If you're a practitioner, I recommend this course to you because it's actually going to change your practice in ways you can't possibly imagine now. When I talk about what it really does, I sound like a snake oil salesman. But the short version is FSM is a new tool that solves these old problems in very particular and effective ways. There's in 4 days there will be 8 practice sessions, practicums. Get your hands on patients. You learn how to use the frequencies in real time, real practice. Be forewarned, frequency specific microcurrent will change your life, your practice, and your outcomes forever. Everything changes when you use the frequencies. And I guess that's our webinar. Do we have any questions out there? Okay. Well,
click on the chat.
I don't have a little chat thing. Oh, Heiko has a question, so he's going to email that to Kevin. Those of you that are going to check out now, I recommend that you come to the website and buy a copy of the Resonance Effect to find out what we're doing. If you want to come take a core seminar, there's a coupon for $200 off of the core seminar or the DVD training, so you can take the course on DVD and then schedule with one of our practicum instructors for the practicum hands-on portion of it. The core 200 is the coupon code for the website, CORE200, gives you $200 off. We have upcoming seminars, June 22nd to the 25th in Philadelphia, July 14th through 16th in Denver, Jacksonville, September 21 to 24. And we go to Jacksonville instead of Orlando because I have friends in Jacksonville and I like to go visit. Chicago, October 26th to the 29th, and don't have a seminar in November, and I'll be teaching in Germany in December. So I wish you well. Please join us, and I will talk to you next month.